This is really a great applicator, and when I came down to Hialeah, I was really impressed with the facility you have there, so kudos, really. As we go through the intro to the brachy stuff, and I'm sure many of you have know some brachy, so if I'm going too fast, please stop me. But just keep this in the back of your mind. We're treating rectal, low rectal, and anal cancers with this applicator. The management of this patient is difficult and often includes APR surgery and use of a colostomy bag. And so this really is something that we want to use for patients who are either don't want the surgery or are not surgical candidates. So this would ideally, if the clinical data that comes out of our study suggests, will be a replacement to APR.
What does APR stand for?
It's abdominal pelvic resection. So they essentially remove the whole rectum and the tumor volume, and then you end up with a colostomy bag afterwards.
Thank you.
Yeah. So I'm going to talk a little bit about radiation therapy and then move into narrow down into brachytherapy, narrow down further to HDR, and talk about the principle of how HDR works. Now, there are various vendors out there, so I'm going to give you a caveat up front that this is more general, and it's not supposed to be a specific guideline to any one vendor or any one treatment planning system. Also, if some of you are used to using any of the balloon breast applicators for APBI, the procedure for that is very uniform because you're treating breast and only breast, and it's only female breast. So there's a lot less variation in the type of structures and things that you are going to do. So you can have a very well-defined protocol. So the guidelines that I'm going to give you and what I'm going to show here is a little more fluid and really depends on the facility's experience and on clinical judgment of the physician and the team. And then we will go into the AR applicator and how we do the planning. I'll show some examples of what we've done here in terms of preparation, planning, and then treatment. So we'll go from essentially end to end, and I'll show you what's expected in this procedure. The purpose of radiation therapy is to kill tumor cells, and that's no news. You all know that. And we use this with radiation, and any type of radiation can be used. We can use X-rays or gamma rays. The difference between them is semantic. X-rays are originate in the electron shells of the nuclei of the atoms, and the gamma rays are emitted from the nuclei themselves. But once you see them, they're emitted in a beam or in a certain spectrum. They're just photons, and you really don't know the difference. There's no way to tell the difference either by energy or by the way they behave. We're talking about the different types of radiation, about X-rays and photon and gamma rays. You can treat with beta particles. You can treat with heavy particles, protons, alpha, etc. Keep in mind, absorbed units, absorbed dose, the unit is gray. It's a unit of energy absorbed in tissue, so it's really 1 joule per kilogram. And it's not directly related to the biological effect of what you're seeing, and I'm going to talk about that in a minute. Many times you're going to see people refer to rads instead of gray. That's the old unit, and 1 rad is 1 centigrade. So 100 rads are 1 gray. Essentially, the difference between the different types of ionization of radiation is how they interact with matter. And you can have radiation that is partially ionizing, which means that as the particle traverses matter, it has sparse ionization along the particle track. Or you can have other particles that are very densely ionizing, and there's obviously a whole range of between sparsely and densely ionizing radiation. And what we're going to talk about is sparsely ionizing radiation. We're talking about photons. And so all photons are sparsely ionizing. The reason that this is important is because depending on the type of radiation and depending on some other factors and dose rate, which we'll talk about in a minute, you can have different types of cell damage. So you can have lethal damage, which is irreversible. It cannot be repaired, and it leads to cell death. And after lethal damage, the cell, even if it's not fully dead, we call it dead because it can no longer reproduce and it cannot no longer do any harm. You can have potentially lethal damage, and this is really something that is can be modified by modifying environmental aspects after the radiation has been delivered. Sublethal damage is something that is naturally being repaired in a few hours, unless you give another dose of radiation or you change something along the way. So when you talk about dose rate, okay, the higher the dose rate, the higher the biological effect. And so it's not just a matter of how much dose you're giving, but it also has to do with how fast you're giving that dose. So what you see here, there are several, so you go from low dose rate, very low dose rate, where the rate of cell kill is very low. So what we have here is a surviving fraction of the cells as a function of dose delivered. And the different curves here show you different dose rates. So you see as the dose rate increases, the surviving fraction of cells decreases as well. Also note that the relationship between dose and the cell survival is not linear. It's a semi-logarithmic. It's a logarithmic relationship. This is important because we're going to be dealing with high dose rate delivery, okay, of radiation. And you should also keep in mind that this does not only apply to tumor cells, but it also applies to healthy tissue. And so when you're giving a high dose rate of radiation, you would also expect higher toxicity. And so it's very important to be able to tailor your dose in such a way to properly spare healthy tissue. So what is the difference biologically between high dose rate and low dose rate? What you really want to take away from this slide here is that for high dose rates, you have no proliferation. If you go for low dose rates, you can have proliferation. You can have, even for when you have LDR permanent implants, seed implants, which many of you are familiar with, you're going to have both repair and proliferation. When you have HDR, there is no proliferation. Okay, and this is what HDR means. Okay, when people usually compare HDR and LDR, they say, oh, one is above 12 gray per hour, the other one is less than 12 gray per hour, or HDR is the machine that people have in their vault next to the LINAC. No, HDR means the rate in which radiation is delivered, and if that rate is high enough to be comparable to compare with the rate of proliferation, then this is considered HDR. And it can be delivered with any type of radiation. In fact, treatments with LINACs or with protons are also HDR treatments, and that's why we fractionate them. Ideally, what we want to do is achieve an ideal fractionation scheme where you give multiple fractions and you achieve very low survival in the tumor while sparing healthy tissue. And this is essentially what a survival curve for multiple fractions look like. So you have multiple fractions delivered over time. Taking this and saying, well, what is brachytherapy? How does brachytherapy come into this? Well, brachytherapy is defined, the term brachytherapy is derived from the Greek. So brachy is close as opposed to tele, which is far away, and therapy is just a treatment. So it's a treatment at close range. Well, what does that mean? It means that you have sources that are placed inside or very close to the tumor. And this is a fuzzy definition. Just as an aside, you know, there's new vendors out there that are producing new devices and new electronic machines, and they're calling them brachytherapy, where the source is really not abutting or inside the tumor. And so the question is what is radiation therapy? And ABS, which is the American Brachytherapy Society, and ASTRO have been struggling with the definition of what is a brachytherapy. How do you know that one device is brachytherapy and the other one is not? And it makes a little bit of a difference when it comes to reimbursement and billing and so on and so forth. But, you know, in general, it can apply to any type of radiation and any dose rate. And traditionally, we have been using radioactive isotopes, but electronic brachytherapy is now being introduced, and so this is available as well. And so just to give you a little bit of an idea of what brachytherapy sources look like, on the right-hand side, you have LDR seeds, and on the left side, you have an example of an HDR source. So you see that they're about the same size. They're about 5 millimeters long. HDR source, this one is the gamma-met source, and it is about 5 millimeters long. It's 0.9 millimeters in diameter. So the size is really very similar to the size of an LDR seed. And if you've seen an LDR seed fall on the floor, you know it's very hard to find, so imagine losing an HDR source. Those sources are welded to a metal cable, so hopefully you'll never have to look for one. But when we practice, for example, emergency procedure and we rehearse disasters, the worst-case scenario is that the source will actually break off the cable. And so you need to be prepared, or the physicist and the physician in any facility need to be prepared for such an occasion. Why does brachytherapy work? It's because you can deliver extremely high, often ablative radiation doses in volumes that are very close to the source. So good placement of the source will give you a very, very high dose to your target volume. You can push away or place the sources in such a way that healthy tissues are far enough away so that they can get a minimal or no dose at all. And so this type of scheme where you can place the source for itself increases your therapeutic ratio. So this makes this type of radiation highly conformal, as opposed to external beam therapy, where radiation is coming in from the outside, and you have to tailor the beam or use arcs or many beams to be able to get a highly conformal treatment. With brachytherapy, it is inherently conformal. So where can it be used? It can really be used anywhere where the physician or the surgeon has access to. So you can stick a needle or stick an applicator or catheters in an orifice, or you can do it intraoperatively. The reason it is not used more commonly is because it is invasive. Many times it is invasive. It may require anesthesia or surgery, and it is also very localized. And so in cases where you need to treat other tissue, lymph nodes or the whole torso or the whole pelvis, this type of radiation is not necessarily suitable. So what you would often find is that physicians opt either to go with external beam or there's a combination of external beam and brachytherapy. So what we're going to focus on is HDR brachytherapy, which is high dose rate brachytherapy. We're going to stick to units that are using iridium-192 sources. The iridium-192 is largely a gamma emitter. It has a half-life of 74 days, and it is considered a high-energy source with an average energy of about a third of an MeV and a peak energy of just over 1 MeV. And just to give you an idea, this is comparable to the energy from cobalt. So if any of you have had experience with old cobalt machines for teletherapy, you're talking about the same energy range. A cobalt machine has an average energy of 1.25 MeV, which is over 1,000 keV. So due to the high energy and high dose rate, you have to use a remote afterloading, and you have to use a shielded room. A remote afterloading is a unit that I will describe that houses the source and controls the source, controls the treatment of the source remotely. So everybody except for the patient are outside the room, and this is all done remotely. Let's talk a little bit about activity and what is the activity of the sources. So activity is the number of disintegrations per unit time, and typically we're talking about 1 becquerel, which is 1 disintegration per second, which is the new unit which is endorsed by the AAPM, American Association of Medicine. The older unit is the curie, and 1 curie is 3.7 times 10 to the 10 becquerel. So for an HDR source, typically when an HDR source is installed in the afterloader, in the unit, it is 10 curies, and that is equivalent to 370 gigabecquerels. So just to give you an idea of numbers and quantities. Activity, because it is disintegrations per unit time, it is directly related to dose rate. Okay? So for a given source type, the higher the activity, the higher the dose rate. The lower the activity, the lower the dose rate. So the next property that we sort of touched on is the energy. And so the energy, it's a property of the isotope, and it's fixed. So the energy of iridium-192 is fixed. It doesn't matter how old or new the source is. And we're talking about high-energy photons, so they interact primarily via Compton scatter. And they roughly, all these high-energy sources, whether you're talking about iridium or cesium-137 that has been used for many decades, for intracavitary implants, cobalt-60 or gold that some people are using for prostate implants, and radium, which has been classically used, this is the classical source. These are all behave as 1 over square, and so it makes it very useful if you ever want to refer to old tables or refer to some other classical treatments. All these sources are very comparable. They all roughly follow the inverse square law. So to summarize what we've talked about right now is you have a high activity source, you have a high energy isotope, and you're delivering the dose with a high dose rate. And that means that when you put all those things together, you have a high risk treatment, okay? So if something goes wrong, there's a likelihood that the consequences will be disastrous. And so QA and making sure that everything goes well and proper preparation is really super important in every time we go into HDR. Going into what's available, there are a variety of afterloaders out there, okay? The main players are Varian, Nucleotron, which is now all owned by Elekta, and Bebig, which just recently, this spring, got FDA approval for their system. Varian has 2 lines of afterloaders, the GammaMed and the VariSource. The GammaMed is the one that we have here at Sloan Kettering. The Elekta Nucleotron has 2 lines of afterloaders, the MicroSelectron, which is being phased out, and the Flexitron, which is replacing it. Eckert and Ziegler have the multi-source and the Staginova. The multi-source is actually an interesting unit because it can have 2 different isotopes, the iridium-192 and the cobalt-60. And the cobalt-60 has a half-life of 5 years. You can see that for, let's say, for developing or third-world countries that want to use the source and not have to buy a new source every 3 months, this could be a very attractive solution. So this is what the GammaMed afterloader looks like. The unit head is where the source is housed, and the indexer can accommodate up to 24 channels. This is where the source would come out. Each channel, the source would be extended, each channel at a time, and as the program, as the treatment plan dictates.
Gil.
Yes.
Hey, Gil. Hi, this is Ken Larmore. I'm sorry to interrupt you, but would you go back to the previous slide?
Yes.
And, okay, thank you. The Eckert and Ziegler that has the iridium 192 and the cobalt 60,
Yes.
I may have missed it, but is there, could you clarify where the iridium 192 and the cobalt 60 would be used in different tumor beds, or why would they have two different sources of radiation?
They would, well, the iridium 192, because it has a half-life of 74 days, is typically replaced every 3 months, 3 to 4 months. Some places, because they have so many patients, they don't want to wait for the source to go down to half its activity, and they change the source every 10 weeks. So they have 5 or 6 sources a year instead of 3 or 4 sources a year. It all depends on how many patients you have and how quickly you want the treatments to be. Remember, if the activity of the source is very low, your dose rate will be that much lower as well. And so it will take that much longer to deliver the same dose had it been a new source compared to a new source.
I see.
Okay? So if you're in a developing country and you don't have the funds and the resources to have sources shipped and changed 3 or 4 times a year, or even more than that, you may want to consider a cobalt 60 source that has a half-life of 5 years. So maybe even if you don't want to wait the 5 years, you can change it every 3 years. That's much better than doing it several times a year.
I see. I see. Thank you.
It would also save you some money. And in terms of where it would be used, I don't think that would be a difference because, remember, these are both high-energy sources, and they both behave pretty much the same. They both follow the inverse square law, which describes the fall-off. I will show that in the next few slides, describe how the fall-off from the sources is. So
okay, great.
Clinically, the use is the same. It's just a practical distinction.
One thing I'd like to say about that, Ken, is I would be hard-pressed to imagine you're ever going to encounter that in a U.S. center.
Right, sure.
The iridium 192 is the standard in the U.S. If a center was using cobalt, it would really be a matter of how it impacted their treatment planning, and would have very little effect on yours and my end of things.
Okay. All right. Perfect. Thank you very much.
Yeah, yep. I don't think it would affect treatment planning that much either. It's really just about the resources in the clinic. So these are very common. They have quite a few units of those in Russia, in Eastern Europe, in other parts of the world, in South America. So as you go international with this, you will see some of those, not in the U.S., but you will see them elsewhere. So back to our Galloway unit. So the source is housed in the safe behind this indexer, and it extended through those channels, through those little holes in the indexer. The machine can go up and down to reach the patient, depending on where the patient is. The base houses electronics and spare batteries, so power that is fed into the afterloader is used to charge the batteries, and the operation is done off battery power, which is more stable. Also, in the case of loss of power or in case of an emergency, the power from the batteries is used to retract the source into the safe position. So this is also a safety consideration. The machine communicates with the control panel and a PC that stands next to it via a data cable that's in the back, that comes in the back of the machine. And usually the typical scenario where you're going to see those machines, they share a room with a LINAC. So you will see an enclosure, either a closed or maybe a chain that locks the machine to the wall, and during treatment you open it or unlock it and get the machine outside. You will also always see an emergency container next to it. So in case there's a radiation emergency and the source is stuck outside the safe the safe of the machine, you can put it into the safe and get the patient out of the room, close the room, and sort of have a semi-safe environment until the vendor comes in and resolves the issue. Control of the machine is done from the control pad that is near the console outside the room, or inside the room. There's a panel on the back of the machine that has several buttons. So you can raise the machine up and down, retract the dummy source. There's an emergency button, a LED indicator, a key to unlock the safe, and various controls. In the back of the machine, there's also a lever that allows you, in case everything fails, to manually retract the source. Don't worry, you'll never be asked to do this, but this is something that physicists and physicians are trained to do in case, again, there's a radiation emergency. And these are features that, I'm describing the gamma med, but these are very basic features, and one way or another, every afterloader incorporates all these features. How is the source extended into a device or a needle placed in the applicator? So what we use are source guide tubes, or sometimes they're called, and this is the one that we use with the gamma med for the Capri applicator. One side goes into the afterloader, plugs into the indexer, and the other side locks onto the catheter or the connector on the applicator side. The combination of length is very important. You want to make sure that you have the right length, overall length, from the machine to the tip of your applicator. Most of the errors in brachytherapy are due to incorrect geometry. And for gamma med, that length from the face of the machine to the end of the applicator is fixed. And the machine itself will check for this. But not all afterloaders do that. So if you go to a facility that has a nucleotron unit, they will go through extra steps of QA, of measuring each catheter, entering that measurement in the treatment planning system, and then double-checking it to make sure that everything is programmed correctly. This particular source guide tools, when used with the AR applicator, will ensure that you have the correct overall length. So this is fixed and does not need to be changed. Should not be. Okay. So how is the treatment being delivered? Essentially, you have an applicator and you have a source wire that sends the source cable, just like the one we saw before, that extends the source into the tip of the applicator. And then this is where the tip of the applicator is. This is in the patient. The proximal end of the applicator hooks up to the source guide tubes, and that goes towards the afterloader. There are actually two wires in the machine. One is an active source wire, and one is an inactive or dummy source wire. So all the checks are done with a dummy, and once the machine and all the QA is done, the machine will send the active source out. And this is what essentially a simplified geometry. The afterloader is programmed to extend the source to any position along that applicator or catheter. So this we call a dwell position, and the time spent in that position is called a dwell time. Okay? When you do this type of treatment with a single dwell position, it is it's considered the simplest treatment. It is used, for example, when we treat skin or when we use a mammocyte balloon with a single dwell position in the center of the balloon. And essentially what you will get is a dose distribution that looks like that. It's very close to a circular dose distribution. Small variation because of the anisotropy of the source, because of self-absorption of radiation inside the source and sometimes in the applicator if you have shielded applicators. But essentially, you cannot tell it from this picture. The source follows the dose intensity from, or the dose rate away as a function of distance from the source, falls off as 1 over r squared for a point source. So moving on, you can add dwell positions. So you can have the source programmed to stop at different locations along the catheter. When you have this type of geometry, you have an aggregate, you have a superposition of all those doses from a single source, and the fall-off then becomes roughly 1 over R squared when you're close to the applicator. And this is a type of treatment that is used for intraluminal, like esophagus or bronchus. So if you're using the EAP, roughly your dose fall-off away from the applicator will be 1 over R. It's also used for vaginal cylinders. So just to show you, here is a CT plan of a vaginal cylinder, and you see the dose, the superposition creates an elongated dose distribution. And you can change it and you can play some games. You can make the dose a little higher at the top, a little lower at the bottom. But remember, you only have a single line of source. So your treatment is cylindrically symmetric. You have some flexibility due to the increased number of dwell positions, but still you have a limited capability of modulating the dose distribution. So, for example, when we'll talk about the EAP later, it is very important to make sure that your spacing is right, that your geometry is correct, because the surface dose in this type of treatment is of concern. You don't want to give too high a dose to the mucosa just because you want to treat far away into tissue. When you increase the number of catheters and you have all these number of dwell positions, you're increasing the number of degrees of freedoms in your treatment, okay? In what you can do, in where you can place the source and how long you can place the source in each position. And so you can get a much more conformal and a much more flexible treatment. And these are used for treatments like prostate, for GYN, whether it's interstitial or tandem and ovoids or a combination. It's used for head and neck, for planar implants, so on and so forth. When we look at that, again, you will notice that each channel has an active length, but we also talk about a treatment length, which is really defined by the volume that we're treating. And depending, some catheters may extend further in, some not, but overall treatment length is defined from the distalmost source position to the inferiormost source position. And this would what we would call the treatment volume. Going further and looking at what kind of doses we give, we are giving, if you're looking at a single fraction, you're giving 15 to 20 gray. And this is the type of treatment that you would typically do intraoperatively. If you're doing fractionated treatment and you're used to seeing, let's say, breast balloons, you're giving 3.4 gray per fractions, and typically times 10 fractions delivered over 5 days. So 2 fractions per day. And the reason those schemes, those different fractionations came about is because they're roughly equivalent to 45 gray of LDR treatment from the old days where sarcoma used to be treated with roughly 10 gray per day or 9 gray per day over 5 days. So this type of, 340 centigrade per fraction times 10 is equivalent to 45 gray LDR. Other treatments that you will look at that you may be familiar with is GYN. Typically people, again, fractionations vary from place to place. You can do 6 fractions or 5 fractions of 6 gray weekly or 4 fractions of 7 gray. You have, what we're looking at is the rectal applicator, and we are currently at Memorial, we are on a dose escalation protocol. Our patients are getting 5 gray per fractions. We are about to complete that stage and go and increase the dose further to make sure to ensure safety and the patients can tolerate the treatment well.
Hey, Gil, this is Ken Larmore again. So if I could ask maybe a general question, and at any rate, I hope this applies. But earlier on, you said that HDR can be delivered with any treatment. And having done some research on HDR in general, and now listening to your presentation, it appears as if using the afterloader catheters and delivering the iridium to the source, it appears as if you're able to much better pinpoint the treatment of the radiation to the affected site. And I guess my question is, whereas it seems as if a beam of radiation delivered would have a more difficult time pinpointing that site, localizing the treatment to that site in the fashion that HDR does. Is that a safe?
That is true with a caveat, because there are treatments that you can read about, SBRT, for example, and SRS, which is stereotactic radiosurgery, or stereotactic radiation therapy, body radiation therapy, where you can actually collimate the beams very tightly around the tumor, and with image guidance, you can get very conformal treatment plans. However, having said that, having the source or catheters right inside the tumor, being able to do so allows you to deliver much higher doses that you will ever be able to deliver safely with either SBRT or SRS.
Okay, and you actually just brought up another question that I had.
The problem is that this is invasive, so you may not always be able to do that.
Okay, gotcha. But these sources through the catheters, they are generally placed inside the tumor and not around the outside necessarily?
That depends on the geometry. Okay. So for example, the prostate is your target volume, and there are foci of tumors inside the prostate that you want to treat. Okay. Mm-hmm. So we are treating the whole prostate, and the catheters are inserted inside the prostate. Okay. What we're going to do, for example, with the AR, or what we're doing with the E applicators, we're placing the source outside the target, and we're aiming the radiation into the lumen. Away from,
I see.
Okay, so it's not always directly inside. It's not always an interstitial treatment. It can be an intracavitation treatment. It can be a surface treatment, but it's always very close. So you deliver a high dose to the target and hopefully a lower dose to the critical structures.
Okay, very good. Thank you.
Yeah. Gil, do you have any examples of the treatment plan coming up?
Yes. Yeah.
Okay. Yeah. Okay. That'll explain a lot for everybody.
I did this. I went through all this so that when we talk about the plans, we can talk about and why we have the AR applicator. It all comes together. Hopefully, it'll all make sense. So again, just to focus, we're talking about the AR applicator. We're looking for something that will be conformal, high dose, and will allow us to treat various targets. So a little bit about historical experience here. There's a lot of experience giving very high doses with X-rays, with an X-ray tube. This is the Papillon experience from France. These were done largely for visible, palpable lesions. These are not always the lesions that we see, and we want to be able to do this with HDR for either palpable or non-palpable lesions. And our problem right now is that our local control rates are not as good. So we want to be able to dose escalate. We want to give higher doses, but we want to give it in a safe way. And remember, the 1 over R squared, the 1 over R law that we talked about earlier applies here too. Safe means we want to be able to spare the mucosa and spare healthy tissue. So what we need to do is have, and here, look again at the 1 over r squared, and this is really what this is all about, this curve right here. So when you are close to the source, you are at the steep segment of the inverse square curve. So that means that if you want to prescribe to the edge of the tumor, this is your applicator lumen, and you here at this far away from the tumor. This part of the tumor will get a huge dose, okay? The surface will get a very, very high dose. Now, if you have a solid tumor, this is great. But if you have a diffuse tumor, this is not good. If you have a diffuse tumor and you have healthy cells as well as tumor cells in this area, you may want to be in this area of the curve where you give a slightly higher area dose at the surface while still being able to cover here. So the dose gradient here is going to be lower. You want to give a more uniform dose at this throughout the tumor. To be able to do that, you need an applicator that can be both push the tumor away for diffuse tumors, or allow the tumor to get close to the source for solid exophytic tumors. And so this is what the AR applicator is. And the way we achieve it is by having a dual baffle design. So we have an inner balloon that holds where the catheters are mounted, and then we have an outer balloon that pushes the mucosa away. However, we have the outer balloon made out of highly compliant material. So if you have a hard tumor that protrudes from the rectal wall, it will press into this baffle and will inherently come closer to the sources, to the catheters, and thereby we will be able to achieve the dose escalation. So in a sense, we have an applicator that allows us to treat all these tumors, and this is a first. This does not exist anywhere else. This applicator has been designed to be both MR and CT compatible, so you can use it. MR is preferred because you can actually visualize the rectal tumors much better with MR and with CT, and we'll show an example of that later. But essentially, this is what this applicator is all about. So here is an example of how this works. Here, this was done in a phantom, and we took a plastic tube and we put a little bit of epoxy, and you can see how this is pushing in. Okay, how the balloon complies around the tumor, and how the simulated tumor gets closer to the source. So you can give an extremely high dose over here while sparing healthy tissue all around it. Okay, and here is an example where you have a uniform spacing between the catheter and the rectal wall. Now, obviously, this is phantom, and when we go and we look at patient images, it's going to look very different, but this essentially holds. And so this was our phantom, this was our proof of principle that we can actually go ahead and do this.